Welcome back to the Deep Dive. Today, we're doing something a little bit different, something very high stakes. We are simulating the ultimate exam prep session. So imagine this. You're standing in front of the examiners for your MD anesthesiology finals. It's the dreaded long case. The external examiner, you know the one, looks sternly over their glasses and asks, "Doctor, how do you assess this patient's volume status?"
You freeze.
You freeze, and your brain just defaults to central venous pressure, sir.
And then you get the silence.
The silence.
That awkward, terrifying silence. That is the sound of walking directly into a trap. In today's world of anesthesiology, answering CVP to that question is probably the fastest way to lose marks. That silence is the sound of a 20-mark question going down the drain.
It feels like a rite of passage, almost, to get that one wrong. But our mission today is to make sure that doesn't happen to you. We're moving way beyond the blood pressure cuff and the CVP line.
We're going to unpack what I like to call the holy trinity of advanced hemodynamic monitoring,
which is impedance cardiography, cardiac output monitoring, and tissue oxygenation.
Exactly. And this isn't just about what you do in the ICU on a Tuesday. This is pure exam strategy. We're basically doing a focused cram session for the Gujarat University MD anesthesiology exams.
And for this, we're pulling from the big guns. We've got the stack right here. Miller's Anesthesia, Morgan and Mikhail, the ICU book by Marino, and even a little bit of Guyton's Physiology.
Can't forget Guyton.
And we've also been looking at the DNB topic-wise papers, and this stuff is everywhere. Questions like non-invasive cardiac output monitoring and stroke volume variations are. They're standard 20-mark long questions.
They absolutely are. And the difference between a pass and a distinction is structure. It's not just about naming the device. It's about knowing the physics behind it, the limitations, and, the specific buzzwords the examiners are listening for.
Okay, so let's start with that structure. I'm sitting there, pen in hand, staring at a blank answer sheet for a question on advanced hemodynamic monitoring. What's my opening line?
You have to start by defining the paradigm shift. You have to show them you understand that hemodynamic monitoring has evolved. It's not just about checking numbers on a screen anymore.
It's more than that.
It is. It's the evaluation of blood flow and ultimately oxygen delivery to the tissues.
Right. I've heard this talked about as a kind of hierarchy of monitoring.
That's the perfect way to frame it. You tell them we've moved from a focus on pressure, so things like mean arterial pressure or MAP and CVP, to a focus on flow.
And flow is cardiac output.
Flow is cardiac output. But even that isn't the final destination. The real end goal, the top of the pyramid, is perfusion-based monitoring. Is the oxygen actually getting into the cell? That's tissue oxygenation.
Pressure, flow, perfusion. Okay, that sounds like the logical skeleton for the entire answer.
It is, because, and this is a quote you should practically memorize from Miller, and the ICU book, pressure is no guarantee of flow.
You can have a perfectly normal blood pressure, but still be in profound shock.
Profound shock. The patient is vasoconstricted down to nothing. The blood pressure reads 1280, but the kidneys aren't seeing any blood flow. That's the shock with normal BP trap.
Okay, so the clinical goal, the reason this whole topic matters,
is to optimize oxygen delivery, which we call DO2, to meet the body's oxygen consumption, or VO2. I mean, if you don't mention DO2 in that first paragraph, you're missing the entire point of why we do this.
All right. So before we jump into the shiny new toys like impedance and NIRS, we kind of have to dismantle the old way of thinking. Let's talk about the limitations of conventional monitoring. Why can't I just rely on heart rate and BP?
This is a very, very high-yield section for your answer. And Marino's ICU book is famous for this data point. Tachycardia and hypotension are late signs of shock.
Okay, but how late are we talking here?
We're talking about a patient potentially losing up to 30% of their blood volume before you see supine hypotension.
30%? That's terrifying. That's a massive amount of blood, and the monitor might still read 12,380.
Absolutely, because the body's compensatory mechanisms, that sympathetic surge, clamps down the blood vessels to preserve pressure at all costs. But flow to the organs is plummeting. Morgan and Mikhail says it explicitly. Normal blood pressure does not guarantee adequate organ perfusion.
Okay, and that brings us to the big one. The CVP. The examiners seem to love to hate the CVP. Why is it such a villain in the modern exam setting?
Well, it's not really a villain, it's just deeply misunderstood. The consensus from both Miller and Marino is crystal clear on this. CVP, or central venous pressure, is a poor marker of intravascular volume.
And an even poorer predictor of fluid responsiveness.
An even poorer predictor. So that old idea of the CVP is the gas gauge in the tank, that's just wrong.
So what is it reflecting then, if not the volume?
It reflects the interaction between right ventricular function and venous return. Think of it as a back pressure, not a volume measurement. You can have a really high CVP in a patient with right heart failure who is desperately dry and needs fluid.
And conversely, you could have a low CVP in someone who's already on the flat part of their Starling curve and won't respond to more fluid.
Exactly. So the key phrase you need to write down, the sentence that gets you the marks, is this. Static parameters like CVP and BP are poor predictors of volume responsiveness.
Static parameters are poor predictors.
Got it.
Okay, that takes care of the old school. Let's move to the second pillar. Cardiac output. This is the flow part of our Trinity.
Right. This is the absolute core of the exam paper. You have to start with the definition. Simple stuff. Cardiac output, or CO, equals stroke volume SV times heart rate.
And Guyton defines it as the quantity of blood pumped into the aorta each minute.
Correct. But to really score well, you can't just stop there. You need to break it down into its 4 determinants.
Okay, that's preload, afterload, contractility, and heart rate.
Perfect. Preload is your end diastolic volume, that's Starling's law. Afterload is the impedance to ejection, which is mostly systemic vascular resistance, or SVR. Contractility is just anotropy, the squeeze of the heart. And heart rate is the multiplier. But here's the critical link you have to make. Why do we even care about monitoring CO?
It goes right back to that oxygen delivery equation you mentioned.
Yes.
From the ICU book.
Yes. DO2 equals CO times CaO2. Oxygen delivery is cardiac output times the arterial oxygen content. In a state of shock or critical illness, the body's demand, VO2, often outstrips the supply.
And we can't just, make more hemoglobin in the middle of a crisis.
Exactly. We can give blood, but that takes time. The one variable we can really dial up or down in real time is the cardiac output. We give fluids to increase preload, we give vasopressors to change afterload, we give inotropes to improve contractility. Monitoring CO lets us see if those interventions are actually working to balance the equation.
It's the only part of the equation we can actively manipulate on a minute-to-minute basis. Okay, so how do we measure it? I need a classification system for the exam.
The easiest way is to categorize them by invasiveness. So you have invasive, minimally invasive, and non-invasive.
Invasive is obviously the big one, the pulmonary artery catheter, the Swan-Ganz.
Historical gold standard, right. It uses thermodilution. Now, Miller is very clear that its usage is declining because, frankly, multiple large-scale studies have failed to show a survival benefit.
So why do we still have to learn it?
Because you can't understand the others without it. It's the reference point for explaining the physiology of all the other devices. You have to know it for the exam, even if you rarely see it in practice anymore.
Okay. Then, minimally invasive.
That's your pulse contour analysis devices. So things like LiDiGo, PiCCO, FloTrac, and esophageal Doppler.
And finally, non-invasive.
And this is where the whole field is moving. This is your impedance cardiography, electrical cardiometry, and bioreactance.
And the rationale for this whole shift is pretty obvious, right? Patient safety.
It's all about reducing complications. Infection, arrhythmia, arterial rupture from the past. We want to get the same or at least similar trend data without putting the patient at risk.
All right, let's do a deep dive into one of those modern topics that you said is extremely high yield. Impedance cardiography. This sounds like pure physics.
It is pure physics. It's based on Ohm's law. Voltage equals current times resistance, or in our case, impedance.
Okay, I remember that from school, but
Yeah.
how do we apply Ohm's law to a person's chest?
The principle is actually really elegant. We pass a very high-frequency, low-amplitude alternating current through the thorax using simple skin electrodes, usually on the neck and chest.
Right.
Now, you have to remember basic conductivity. What in the body conducts electricity well?
Fluids, so blood.
Blood is an excellent conductor. And what's a poor conductor?
Air, fat, bone.
Exactly. So now, think about the cardiac cycle. During systole, the heart pumps blood into the aorta. For a brief moment, the total volume of blood, that conductive fluid in the chest, increases.
Ah, I see. So if you have more conductive fluid, the overall resistance or impedance of the chest should go down.
Precisely. More blood equals less impedance. So Miller explains that the device measures the baseline impedance of the chest, which is called Z0, and then it looks at the rate of change of that impedance over time. We call that DZDT.
So it's not the drop itself, but how fast it drops.
It's how fast and how deep that impedance drops with each heartbeat. The algorithm uses that information, aligned with the ECG, to calculate how much blood was ejected. That's your stroke volume.
That's incredible. It's basically counting blood cells with electricity. So what parameters do we get from this?
Well, you get the obvious ones: cardiac output, stroke volume, And you can calculate systemic vascular resistance, SVR, but you also get a really unique parameter called thoracic fluid content, or TFC.
PFC, that sounds really useful for the ICU.
Oh, it is. It's incredibly useful. TFC is derived from that baseline impedance, the Z0. Remember, fluid conducts electricity. If a patient develops pulmonary edema, if their lungs get wet, their whole chest contains more fluid.
Which means it's more conductive. So the baseline impedance should be lower.
Right. A lower baseline impedance means a higher thoracic fluid content.
Right.
The TFC number goes up.
Let's say I'm treating a patient with congestive heart failure. If I give them a diuretic like Lasix, I should actually be able to watch the TFC number go down as their lungs dry out.
That is exactly the application. It gives you a continuous, completely non-invasive trend of their pulmonary fluid status. Mentioning TFC as a guide for diuresis in a heart failure patient is a very sophisticated point to make in your exam answer. It shows you're thinking beyond just cardiac output.
The advantages seem pretty clear. It's totally non-invasive, just a few stickers. But let's talk about the limitations. This sounds like the classic Viva question trap. When does impedance cardiography fail?
Well, the limitations are significant, and you absolutely must know them. First and foremost, motion artifacts. If the patient is moving, shivering, or, God forbid, having a seizure, the electrical signal is useless. Complete noise.
Okay, motion is out.
Yeah.
What else?
Arrhythmias, especially something like atrial fibrillation. The device relies on a regular, predictable cardiac cycle to average its readings. An irregular heartbeat throws the whole algorithm off.
And what about in the operating theater? Surgical interference.
That's a huge issue. If the surgeon is using diathermy or electrocautery, that creates a massive electrical storm in the patient. The impedance monitor just goes haywire. It's completely unusable during active cautery.
Okay. And finally, you mentioned anatomical issues.
Yes, severe valvular regurgitation or large septal defects. These alter that fundamental relationship between flow and impedance.
Can you expand on that? Why does aortic regurgitation, for example, mess it up so badly?
Sure. Think about what the device is measuring. It's measuring the total change in aortic blood volume during systole. It assumes all of that blood is going forward out to the body.
But in severe aortic regurgitation, a lot of it comes right back.
A huge chunk of it flows backward into the ventricle during diastole. And the forward flow is often turbulent. The device just sees this massive change in impedance and calculates an enormous stroke volume.
But the effective forward flow, the blood that's actually perfusing the body, is much lower.
Exactly. So it will drastically overestimate the true cardiac output. The clinical pearl here is simple. If the patient has a known significant leaky valve, do not trust the bioimpedance monitor for an absolute number. It might still trend, but the number itself is likely wrong.
Okay, let's move on to the other big category, pulse contour analysis. This is everywhere now. The FloTrac, the PiCCO. What's the underlying concept here?
The concept is that the arterial pressure waveform, the little squiggle you see on the monitor from an art line, contains a ton of hidden information. The area under the systolic portion of that pressure wave is proportional to the stroke volume.
So a big wide wave means a big stroke volume, and a thin, spiky one means a low stroke volume.
In a nutshell, yes. But here's the catch. To go from a pressure area to an actual volume in milliliters, the device has to know how stiff or compliant the patient's aorta is. And that brings us to the really important distinction between calibrated and uncalibrated systems.
Yeah, what's the difference there?
Calibrated systems, like a PiCCO or a Litio Plus, don't just guess. They use a reference method, usually transpulmonary thermodilution or lithium dilution, to measure the actual cardiac output once.
So they get a true gold standard number first.
Right. And then they use that number to calibrate the pulse contour algorithm. They're essentially telling the machine, for this specific patient, an area of this size equals a stroke volume of this many milliliters. It corrects for that individual's aortic compliance.
Okay, and the uncalibrated systems?
The uncalibrated systems, like the FloTrac, are much simpler. They use demographic data, age, height, sex, and internal nomograms based on large population data sets to estimate the patient's aortic compliance. They don't need that external calibration step.
That sounds a lot easier, but
yeah.
What's the catch? Is it just as accurate?
And that is the million-dollar question. Marino's ICU book has a pretty stern warning about this. In stable patients, they work reasonably well for tracking trends. But in a state like septic shock, where you have profound vasodilation and the aortic compliance is changing by the minute,
The estimate is going to be wrong.
the uncalibrated systems can really struggle to keep up. Their accuracy can degrade significantly in patients with chaotic and rapidly changing vascular tone.
Okay. And just briefly, what about esophageal Doppler?
Think of it like a simplified T, a transesophageal echo. You put a thin probe down the esophagus, point it at the descending aorta, and use the Doppler effect to measure the velocity of the blood flow.
And from velocity, you can get flow.
Right. The formula is flow equals velocity times the cross-sectional area of the aorta. Miller notes that it's highly operator-dependent. You have to aim the probe just right. But for tracking beat-to-beat changes intraoperatively, it can be very effective.
All right, so we've covered flow. Let's move to the top of that pyramid. Tissue oxygenation and perfusion monitoring. This feels like the so what factor of the whole discussion.
It is exactly that. You can have a beautiful blood pressure, a textbook cardiac output, but if your microcirculation is clamped down and the cells are starving for oxygen, none of it matters. This is the fundamental conflict between macro-hemodynamics and micro-hemodynamics.
I've seen the term occult hypoperfusion used for this. The patient looks good on the monitor, but they're secretly dying inside.
That's it. And the exam statement you need to memorize, the one that shows you're thinking at a higher level, is normalization of systemic hemodynamic variables does not guarantee adequate tissue oxygenation.
That's a powerful sentence. So how do we peek behind the curtain? How do we monitor tissue oxygenation?
We really have three main tools in our clinical toolbox for this. There's central venous oxygen saturation, or SCVO2. There's near-infrared spectroscopy, NIRS, and of course there's lactate.
Okay, let's start with SCVO2. How does that work?
This is a measurement you can get from a standard central line, a CVP line, as long as the tip is in the superior vena cava. It's a surrogate for the true mixed venous oxygen saturation, or SCVO2, which you'd need a PA catheter to get. A normal SCVO2 is greater than 70%.
And what does it mean if it's low, say 55%?
A low SCVO2 is pretty straightforward. It means the tissues are extracting a much higher percentage of oxygen from the blood than normal. This usually happens for one of two reasons. Either oxygen delivery is low,
Low cardiac output, low hemoglobin, low arterial saturation.
or oxygen demand is unusually high. Think of a patient who's febrile or shivering uncontrollably. The metabolic rate is through the roof.
Okay, but what if it's high? That's the one that seems counterintuitive.
That's the tricky one. A high SCVO2, say 85%, can mean two very different things. The good reason is that you're supplying way more oxygen than the body needs, but the dangerous reason is that it can indicate shunting or cellular poisoning. In early hyperdynamic sepsis, blood can bypass the capillaries through arteriovenous shunts. The blood just zips right past the tissues without ever delivering its oxygen. Or, in a state like histotoxic hypoxia, think cyanide poisoning, the cells simply cannot use the oxygen that's being delivered. The blood comes back to the heart still bright red because the mitochondria are dead or dying.
Right. So a high SCVO2 could actually be a sign of impending doom.
It could be. You have to interpret it in context.
Okay, that NIRS, near-infrared spectroscopy, this seems to be a real exam favorite these days.
It is, because it's non-invasive and gives us a window into a specific organ. The principle relies on the Beer-Lambert law. Essentially, near-infrared light can penetrate tissue, even the skull, and it gets absorbed differently by oxygenated hemoglobin versus deoxygenated hemoglobin.
So what is it actually measuring? It's not the same as a pulse oximeter, right? It's not arterial saturation.
No, and this is a critical point to understand. It measures regional oxygen saturation, or RSO2. But here's the key. It is a venous-weighted signal.
Okay, why is it venous-weighted? That's not obvious.
Because if you take any random chunk of tissue, about 70 to 75% of the blood volume within it is in the capillaries and venules, not the arterioles. The arterial blood is just passing through quickly. So the NIRS signal is dominated by the venous side.
So it's telling you about the oxygen level after the tissue has already taken what it needs.
Precisely. It's a direct reflection of the balance between oxygen supply and oxygen demand in that specific patch of tissue.
And where do we use it most often?
Primarily for cerebral oxygenation. It's like an early warning system for the brain. We use it during carotid endarterectomy, during cardiac surgery when you go on bypass or have circulatory arrest, or in the beach chair position for shoulder surgery where you risk brain hypoperfusion.
So if that NIRS number on the forehead starts to drop, it means the brain is struggling, even if the blood pressure in the arm looks totally fine.
That's exactly it. It can catch cerebral ischemia minutes before it would become apparent otherwise, giving you time to intervene before the damage is permanent.
But it must have limitations.
Of course. The biggest one is signal contamination from extracranial tissue, the scalp. If the scalp gets cold and vasoconstricted, it can drag the number down even if the brain itself is perfectly well perfused. And it's also very sensitive to ambient light interference.
Okay, and just to round it out, lactate.
Lactate is our classic metabolic marker of anaerobic metabolism. The ICU book makes a very important point here. While the absolute lactate level is important, it's the lactate clearance that is the real prognostic marker.
What do you mean by clearance?
It's not enough for the lactate to be high. You have to see it coming down with your resuscitation. If you're treating a patient in shock and their lactate isn't clearing, if it isn't decreasing by, say, 10 to 20% every couple of hours, that's a very poor prognostic sign. It means your resuscitation is failing at the cellular level.
Okay, so we have all these tools now. Let's talk about clinical applications. How do we actually put this all together in the ICU or the OT?
This brings us to the modern concept of goal-directed therapy, or GDT. The idea is to use these advanced monitors, particularly stroke volume, to guide our fluid and inertrope administration to hit specific targets before the patient develops organ failure.
So it's about being proactive instead of just reacting to a low blood pressure.
It's the definition of proactive care. And Miller cites a fair bit of evidence showing that in high-risk abdominal surgery, for example, this approach can reduce hospital stay and major complications. We're not just giving fluid blindly, we're giving it to achieve a target stroke volume.
And this ties directly into the whole concept of fluid responsiveness, the so-called dynamic parameters.
Yeah.
We're talking about stroke volume variation, SVV, and pulse pressure variation, BPV.
This is probably the most practical, clinically relevant part of the entire topic for your exam. You have to be able to explain the heart-lung interaction that makes this work. This is the dynamic approach that's so superior to the static CVP we were bashing earlier.
Okay, let's unpack that mechanism slowly. It's a little tricky to visualize.
Imagine your patient is on a mechanical ventilator. When the ventilator pushes a breath in, it creates positive pressure inside the chest.
Okay, so it's squeezing everything in the thorax.
Right. It squeezes the great veins, the vena cava, and the right atrium. This temporarily impedes venous return.
So less blood gets back to the heart.
For a moment, yes, the preload to the right ventricle drops, which means a moment later, the RV output drops. Now that smaller slug of blood has to travel through the lungs. This takes a few heartbeats.
And then that smaller volume of blood arrives at the left ventricle.
Exactly. So now the left ventricle has less blood to pump out. So the left ventricular stroke volume drops, and you see a dip in the arterial pressure waveform. The ventilator breath causes a cyclical swing in the blood pressure.
So if I'm looking at the arterial line on the monitor and I see it swinging up and down in time with the ventilator breaths, that's what we're talking about.
That's SVV. And if that variation is large, the general threshold is more than about 12 to 13%, it tells you the patient is a responder.
Meaning they're on the steep part of the Frank-Starling curve.
You've got it. It means their heart is very sensitive to preload. If you give that patient a bolus of fluid, their cardiac output will shoot right up.
And if the SVV is low, say 7%.
If it's low, below 10%, it means they're on the flat part of the curve. Giving them more fluid probably won't increase their cardiac output much, if at all. You'll just end up congesting their lungs. Their tank is full.
But, and this feels like a huge BUT, there are very strict limitations. This is the classic Viva trap. When can you not use SVV?
You absolutely must memorize this list. SVV and PPV are invalid if 1, the patient has an arrhythmia, atrial fibrillation completely ruins the calculation. 2, the chest is open, like during cardiac surgery. You lose that pressure seal.
Right.
3, the tidal volume is too low. You generally need a tidal volume of at least 8 milliliters per kilogram to generate enough of a pressure swing to actually test the heart.
Okay. And what's the biggest one?
The biggest one, the one they always ask about. The patient is breathing spontaneously.
That is crucial. Do not look at SVV in a spontaneously breathing patient. Why is that?
Because spontaneous breathing is completely irregular. The depth of the breath varies, the timing varies. You need that consistent metronome-like pressure swing from a ventilator for the math to work. Plus, a spontaneous breath creates negative intrathoracic pressure, which reverses the entire physiological principle we've just discussed.
Okay, that makes sense. Let's try to put this all together. If I have to make a comparison table for my exam answer, comparing all these different monitors, how should I structure it?
Go back to our original framework. Pressure, flow, and perfusion. It's the perfect structure. So for pressure, CVP, MAP, strengths are it's easy, it's standard, it's cheap. The weakness is that it's insensitive and a late indicator of problems with flow and volume.
Okay. Flow, CO via PAC, Doppler impedance.
Strength is, it tells us about global oxygen delivery. It's the engine of the system. The weakness is that it's either invasive, like the PiCCO, or technically complex and prone to artifacts, like impedance.
And finally, perfusion. Lactate, NIRS, SCVO2.
Strength is that this is the ultimate endpoint. This is cellular health. Are the cells happy? The weakness is that it can be a late sign, like lactate, or it might only tell you about one specific region, like NIRS on the forehead.
What are the general limitations and pitfalls across all of these? What's the biggest mistake people make?
The number one mistake is over-reliance on the numbers. It's what we call treating the monitor instead of the patient. You have to integrate the data with your clinical exam.
And technical issues.
Oh, absolutely. Damping of an arterial line is a huge one. Morgan points this out very clearly. An over-damped art line, maybe from an air bubble or a kink in the tubing, will artificially lower the systolic pressure and flatten the waveform. This will completely ruin any pulse contour CO calculation because it fundamentally distorts the area under the curve.
Right, garbage in, garbage out. Oh. Let's look to the future. This is always a good way to end an exam answer, to show you're thinking ahead. Where is this field going?
The two big words are integration and closed-loop systems. We're already seeing monitors that integrate all three levels on one screen. They'll show you pulse contour for flow, continuous oximetry for SCVO2, and NIRS for tissue perfusion, all trended together.
What do you mean by closed loop?
This is the really futuristic stuff that Miller discusses. Imagine a system where the computer is continuously monitoring the patient's SVV. If the SVV creeps up above 13%, the computer automatically triggers the IV pump to give a 100 milliliter fluid bolus. If the SVV drops, it stops the fluid.
So it takes the human lag, the decision-making time, out of the equation.
Exactly. It's still largely experimental, but that's the direction things are headed.
And you mentioned the microcirculation earlier.
Yes. For a really high-level answer, you could mention a research tool called Sidestream Dark Field Imaging, or SDF imaging. It's a special handheld microscope that lets you visualize the capillaries directly, usually under the tongue. You can actually see the red blood cells flowing through. It's not for routine clinical use yet, but mentioning it shows you've read beyond the basic textbook chapters.
Okay, we are nearing the end. Let's hit those common exam questions and Viva traps one last time. We've hammered the SVV and spontaneous breathing trap. What about the difference between SVO2 and SCVO2?
This is a subtle one, but it really separates the candidates who truly understand physiology from those who just memorize numbers. SCVO2 is the oxygen saturation of blood coming back from the upper body via the superior vena cava.
So mainly the brain and the arms.
Right. SVO2, on the other hand, is the true mixed venous sample from the pulmonary artery. So it includes all the blood from the lower body as well. The gut, the kidneys, the legs.
And in a healthy person, the brain extracts a lot of oxygen, right?
A ton. So normally, the blood from the upper body, the SCVO2, is actually a little bit lower in oxygen than the true mixed venous blood.
Okay, but what happens in shock? The whole game changes.
In shock, the body goes into survival mode. It shunts blood away from the gut and kidneys to preserve flow to the brain and heart. But those ischemic organs, the gut and the kidneys, they extract every last molecule of oxygen they can from the tiny trickle of blood they're still getting.
So the venous blood coming up from the lower body is almost completely deoxygenated.
It's pitch black. Meanwhile, the brain is still getting relatively good flow, so when that super desaturated blood from the lower body mixes with the upper body blood in the heart, it drags the overall average, the SVO2, down precipitously.
So in shock, the relationship flips. The SVO2 becomes lower than the SCVO2.
That's the pro tip, and if you can explain that redistribution of flow in a Viva, you're not just passing, you're getting a distinction. It shows you understand the physiology of shock, not just the monitors.
That's brilliant. Now for the written paper, diagrams. What are the must-draw diagrams for this question?
You absolutely must draw three. First, the Frank-Starling curve. Preload on the x-axis, stroke volume on the y-axis. Clearly label the steep fluid-responsive part and the flat non-responsive part.
Okay, Starling curve, number one.
Number two, a simple impedance schematic. Draw a box for the thorax, label it as a resistor. Show Z0 as the baseline impedance and delta Z as the small pulsatile change with each heartbeat.
Right. And number three?
The pulse contour area. Just draw a classic arterial waveform. Shade in the area under the systolic part of the curve and label it proportional to stroke volume. Those three diagrams will make your answer sheet look incredibly professional. Presentation matters.
Absolutely. All right, let's wrap this up with our 1-minute drill, a high-speed summary of the entire deep dive for the drive to the exam hall.
Let's do it. 1. Hemodynamic monitoring has evolved. Remember the mantra, pressure to flow to perfusion.
Do. CVP is not a volume monitor. It's a right ventricular function and venous return monitor.
3. Impedance cardiography is non-invasive CO monitoring based on thoracic conductivity changes, or DZDT, but watch out for motion, arrhythmias, and leaky valves.
4. Pulse contour relies on the area under the arterial curve. Know the crucial difference between calibrated and uncalibrated systems.
5. Fluid responsiveness, using SVV and PPV, is far superior to static preload measures like CVP, but only in ventilated patients in sinus rhythm with a closed chest.
And 6. Tissue oxygenation, SCVO2, NIRS, and lactate is your final check of adequacy. It's all about the micro-hemodynamics.
Perfect.
And to put a bow on it, what's the model conclusion paragraph for the exam paper?
I'd write something like this. In the critically ill patient, the normalization of blood pressure does not ensure survival. We must integrate non-invasive flow monitoring and tissue perfusion endpoints to guide our therapy. The modern approach is to start non-invasive, escalate to more invasive monitoring only if the patient remains unstable, and always link the number on the monitor back to the underlying physiology of the patient.
That's perfect. Well, to everyone listening, and especially those of you prepping for the Gujarat University MD exams, good luck. You have absolutely got this.
You do. Now go draw the Frank-Starling curve. Right now.
We'll see you on the next deep dive.